y ella tiene 33 años. COVID-19 cambió su vida. Ella me dijo que echa de menos sus amigos, su familia, y que no podría vivir su vida normal en meses. Les digo esta historia para recordarles que ser joven no les proteja del COVID-19. De hecho, un nuevo estudio realizado por USC San Francisco encontró que 1 de cada 3 adultos jóvenes quienes fuman mucho pueden enfermarse muy grave a la causa de COVID-19. En abril, personas de 18 o 40 años representaban el 10% de las personas de nuestros hospitales con COVID-19. Ahora representan el 25%. No, you went too fast. Las personas de nuestros hospitales con COVID-19 ahora representan el 25% de las personas en nuestros hospitales con COVID-19. Ahora, 44% de las personas con el virus en el condado tienen entre 18 a 40 años. Por eso les pido no juntarse en grupos grandes con sus amigos. Trate de resistir juntarse en grupos grandes con personas fuera de su casa y mejor conéctase con ellos virtualmente. No se permita reuniones en persona y no vale la pena el riesgo. Y por favor, siempre tengan puesto su mascarilla de tela para la cara. Es obligatorio y como nuestra Comisión de Indios Nativos Americanos nos recordó esta semana, tienen puesto una mascarilla de tela para la cara en un acto de amor. De hecho, estudios enseñan que mascarillas de la tela para los I think we probably, I don't know how you feel comfortable. I think I should read it from my paper. Okay, I think I'll have to read this.
Okay, Larry, are we good?
And ladies and gentlemen, we do thank you for standing by, welcoming you to the LA County COVID-19 update. Everyone joining by phone is in a listen-only or muted mode. Later, we will conduct a question and answer session. Instructions will be given at that time. If you need operator assistance at any time, you may press star and then 0. I'll now turn the meeting over to Supervisor Hilda Solis. Please go ahead.
Good afternoon, and thank you for joining us for today's press briefing. I'm Hilda Solis, Chair Pro Tem of the Los Angeles County Board of Supervisors. I'm joined today by Dr. Barbara Ferrer, Director of the Department of Public Health, as well as Dr. Christina Galli, Director of the Department of Health Services. Dr. Galli will share what we're doing to increase much-needed access to testing. We're expanding the testing capacity at several testing sites in areas of great need, including at East Los Angeles Community College, in El Monte, and Pomona Fairplex. We're also opening up new testing sites, including in the cities of Azusa, Montebello, Southgate, in the coming weeks. And I want to thank our cities for their partnership. Dr. Galli will go over in greater detail regarding this plan, which will help us bend the curve of COVID-19 again. This crisis has intensified. It is getting worse, and it is affecting people of all ages. To underscore the gravity of the situation, I'd like to share the story of a young COVID-19 survivor who I spoke with last week. She is 33 years old and considers herself an athlete. She has been a runner for more than 15 years. In fact, she went on a miles run on the day she started experience COVID-19 symptoms. 111 days later, she is recovering but is still symptomatic. She shared with me that her acute phase of illness lasted over 2 weeks. Her symptoms included severe levels of blood clots, seizures, heart palpitation, shortness of breath, and a terrifying range of other symptoms. Now she is on week 16 of her symptoms. She has not had a symptom-free day in over 3.5 months. Again, she is 33 years old. Still, COVID-19 has upended her life. She told me that she misses her friends, her family, and has been unable to live her full life in months. I tell this story to underscore once again that being a young person does not shield people from the seriousness of COVID-19. In fact, a new study by researchers at UC San Francisco found that 1 in 3 young adults may face severe COVID-19 cases, with smoking playing a big part of the risk. People ages 18 to 40 made up 10% of the county's hospitalizations in April. Now they make up 25% of those hospitalized due to COVID-19. Currently, 44% of people with the virus are ages 18 to 40 in LA County. And that is why I implore you to turn down that invitation to hang out with a group of friends. Resist the urge to join a family gathering and encourage them to connect virtually. In-person gatherings, which remain prohibited, are simply not worth the risk. And please wear your mask. It is required. And as our Native American Indian Commission shared earlier this week, wearing a mask is an act of love. In fact, studies have shown that masks do a lot more to protect you and others around you than you had previously thought. One of the most important discussions right now is whether to reopen our schools. I can't imagine what students and families are going through right now with all of this uncertainty. Likewise, the teachers and staff who would have to take on this monumental task. It is a tough decision to make, but the safety of our children and school employees must come first. If a school district decides and is allowed to resume in-person instruction, then it needs to be cautious and flexible while complying with all the guidelines put forth by the Department of Public Health. This virus is unpredictable, so unfortunately, we need to adapt and do so quickly. If a district is not able to comply with the safety protocols, and if there is too much community transmission, then it should continue with distance learning. This is going to place a huge responsibility on parents and will result in learning loss. It's a sobering reality, but it tells us once again that in order for our schools and economy to reopen, we must slow the spread of COVID-19. Simply put, we must again focus on flattening the curve for our children, for our families, and for the health of everyone. I also want to address the COVID-19 outbreak at LA Apparel. Over 300 garment workers have tested positive, and tragically 4 have died. I recognize this is an unprecedented time for all of us, but the health and safety of employees can't be compromised. That means that safety protocols must be followed. Please visit publichealth.la.gov for more information about these necessary protocols. Businesses are required to follow. And I also want to encourage employees to call 888-700-9995 to report unsafe work conditions. Reports may be anonymous, and there will be no questions about personal information, including immigration status. We share collective responsibility to get through this moment. Thank you all for doing your part. And now I would like to introduce Dr. Barbara Ferrer.
Thank you so much, Supervisor Solis. You've been a steadfast voice for our most vulnerable residents, including those with a higher risk for serious illness from COVID-19, and I'm extraordinarily grateful for that. And good afternoon, everyone. First, I do want to acknowledge that this has been a tough week for our community as we continue to move through these unprecedented times. The difficult decisions that are being made at all levels of government are made to protect the health and safety of everyone who lives in LA County. To put that in perspective, yesterday we reported troubling and startling data. We saw the most cases we've ever reported in a single day, and we also unfortunately had to share that 73 people had died as a result of COVID. To put that in perspective, the most deaths we ever reported in a single day is 76, and that was back in May when we unfortunately had so many residents in our nursing homes that were passing away. We're also seeing the most hospitalizations since this pandemic began. Today's data is just as distressing, and I will update you on this information in a moment. After that, I'll have an opportunity to share some new data we have on who's being hospitalized and the trends that we're seeing in hospital utilization. We are in an alarming and dangerous phase in this pandemic here in LA County, and we're in this place along with 29 other counties across the state. These alarming trends reflect behaviors from 3 weeks ago, and it will take several weeks to see if our behavior now, including the rollback of previously opened sectors, slows the spread of the virus. What we do today impacts our lives in the weeks and the months ahead. We're just not able to continue on our recovery journey without everyone doing their part. Keeping businesses open is only possible if we can get back to slowing the spread. And we do need to remember that all of us play a part in protecting the capacity of our healthcare system so that we're all able to access critical care when we need it. Our efforts also need to focus on the disheartening and devastating reality that here in LA County, our Black and brown residents and those with limited income are disproportionately affected by this virus. And you'll hear more about that today from both me and my Department of Health Services colleague, Dr. Galley. I do want to start with reporting our daily numbers on deaths and case counts, and then I'll offer some broader context on this data, including a focus on equity. I am sad to report an additional 44 deaths today. 27 of the people who passed away are over the age of 25, and 25 of the people over the age of 65 who died had underlying health conditions. 13 people who died are between the ages of 41 and 65, and 8 people in this age category had underlying health conditions. Information on the 2 deaths that are and 1 person passed away between the ages of 18 and 40, and this person did have underlying health conditions. I do want to note that every day for the last 2 weeks, I've reported on deaths that have occurred to people in the younger age group. And I hope folks are taking note. I really appreciated what Supervisor Solis was saying about the fact that, unfortunately, this virus wreaks devastation in every single age group of people who live here in our county. Information on the 2 deaths reported by the City of Long Beach and the 1 death reported by the City of Pasadena are available at longbeach.net and cityofpasadena.gov. This does bring the total number of deaths to 3,932 in Los Angeles County, and 93% of the people who have passed away had underlying health conditions. For the 3,598 people who passed away where race and ethnicity has been identified, 45% are Latinx, Latino, 26% are white, 16% are Asian, 11% are Black, and slightly less than 1% are Native Hawaiian or Pacific Islander, and 2% identified with another race or ethnicity. I'm also reporting 2,758 new cases today, and this does bring the total number of cases in LA County to 143,009 cases. These cases do include 5,849 cases reported by our partners in the City of Long Beach and 1,580 cases reported by the City of Pasadena. We're also confirming 833 cases among people experiencing homelessness, and among these cases, 303 were referred to isolation and quarantine sites where they could appropriately isolate for the duration of their illness. We've investigated now a total of 978 residential congregate settings and non-residential settings with at least 1 confirmed case of COVID-19. And of these, we currently are investigating at 718 sites, and we've closed investigations at 260 sites where they have had no new cases for at least 2 weeks. Residential settings, as a reminder, include nursing homes, assisted living facilities, shelters, treatment centers, supportive living, and correctional facilities. Non-residential settings include workplaces, food and retail, and educational settings. And as I showed you on Monday, it's in the non-residential sites where we're seeing the steepest increase. The total number of confirmed cases in institutional settings is now 22,731, and this includes 13,207 cases among residents and 9,524 cases among staff. I will be able to update the data on the deaths of residents in institutional settings later today, and you'll get that information on our website. We're also reporting 3,284 confirmed cases at some point in time in the jail facilities. This is 2,951 among people who are incarcerated and 333 among staff. The Sheriff's Office is reporting for their facilities today 47 inmates that are positive, 804 people that are incarcerated that recovered, 76 inmates that are in isolation, and 2,545 people who are incarcerated that are quarantined. There are 188 cases in the state prison, 131 are among people who are incarcerated, and 57 among staff. And there are 757 cases in the federal prison facilities. This includes 741 among people who are incarcerated and 16 among staff. And there are now 90 cases in our juvenile facilities, again, a slight increase from earlier this week. 35 are among youth and 55 are among staff. 1,409,712 people have been tested and had their results reported in LA County, and 9% were positive over time. The 7-day rolling average daily positivity rate is now at 9.8%. And can you please put up the first slide? First, I wanted to be able to update you on some data we have on hospitalizations, which, as you know, are increasing, and we're now seeing the highest rates we've ever had since the onset of the pandemic. We have known that since Memorial Day weekend, younger people have been infected at higher rates than before. And if you take a look at the blue line, it now shows us that younger people between the ages of 18 and 40 are also being hospitalized at a significantly higher rate than we've seen before, and it continues to increase. It's almost at 30% now. The next slide, please. This slide shows us the percent change by week on daily hospitalizations, on weekly hospitalizations. You can see that in the last few weeks, hospitalizations have increased significantly, and we are on an upward trajectory. The shift from declining rates to increasing rates happened very rapidly. And we now see a 3-day average of over 2,000 people hospitalized on a given day, which is more people hospitalized each day for COVID-19 than at any other point during the pandemic. This slide mirrors what we're seeing and reporting on in terms of our daily hospitalization rate. Those who are hospitalized and need intensive care, that's also at a higher rate than we've seen before. And I'll take the next slide. And this is troubling because, as you know, care in the ICU is limited. Unfortunately, this is also further evidence that we should probably expect to see an increase in deaths in the coming days and weeks. What this really means for all of us is that we need to start and continue to take the steps that protect our healthcare infrastructure so that hospitals are able to manage the growing number of people that need inpatient care. That is why it's so important to follow the public health directives, like staying home, avoiding close contact with people who you don't live with, and wearing your face covering at all times when you're out of your house. As you know, we also watch a set of daily metrics very carefully so that we can actually make some assessment about how well we're doing on our recovery journey. And today I want to actually share again our 7-day trends and provide a little bit of an update on some of the indicators that we're tracking and again, some of the changes that we're seeing over time. So I'll take the next slide. As you know, we watch the daily, as you know, this graph, which I've shown before, has a 7-day average of the daily reported new cases of COVID-19. And you can see easily how much of an increase we've had this last month. At the beginning of June, the 7-day average of new cases was 1,452, and now we are averaging 2,859 new cases a day. This is double where we were at the beginning of June, and it's higher than it has been at any point in the pandemic. The 7-day average paints a clear picture of what's happening these last few weeks, which really is that we continue to see a sharp increase in what we call community transmission. Our rate of having each of us who's infected infect other people, and the number of people that are infected that are unfortunately out and about in the community capable of infecting others. We'll take the next slide. This slide shows the 7-day average of the daily percent of positive tests over time, which is also now increasing steadily from a low that we had back in May. At the beginning of the pandemic, we were mostly testing people who were sick, and our positivity rate was about 15% in early April. Now, even though we're testing way more asymptomatic people, our positivity rate is just about 10%. Again, a concerning trend. The next slide, please. This slide shows this past 7-day average of daily deaths. And you'll note that it does look like for a while our deaths were on a downward trajectory. And I want to thank everybody who worked so hard to make this possible. But two things to note. One is it's no longer on a downward trend. And two, it's what we call a lagging indicator. And that we're worried that in a few days from now and a week or two from now, we will actually see our deaths increase because they're associated with the increases that we're seeing in hospitalizations. And yesterday, you know, I reported 73 deaths, which is one of the highest daily death totals for the entire pandemic. And today we reported, sadly, another 44 people have passed away. And I just want us to all note and take a moment to silently reflect on the fact that all of the people who passed away were parents, grandparents, siblings, friends, and neighbors, and they've left a huge hold in the lives of their loved ones. And our prayers are with all of them today as they're grieving. I do want to spend a few minutes also discussing issues related to equity and the pandemic. The reality of this pandemic is that people of color and people in high poverty areas are bearing the brunt of this virus. Systematic racism and discrimination remain root causes and the main drivers of the inequities that we see that result in serious illness and death. And unfortunately, a lot of the disproportionality can be traced to the fact that a significant number of essential workers are low income and/or are people of color. They couldn't stay home at work, and early in the pandemic, there were few protections that were offered at many work sites. There were no requirements for anybody to wear a mask or a face covering, and there were no requirements for physical distancing. And also in many places where people went to work who were essential workers, infection control was just not a priority. So we need to focus significantly in order to address the alarming trends. And the first thing we need to do is to ensure that all workplaces offer essential protections to every single worker. And the second thing we need to do is to deploy resources to the hardest hit communities. And some examples of how we're trying to do this include when the research and the data showed that masking and physical distance was key to slowing the spread, public health immediately issued protocols that required businesses to meet stringent requirements so that they could care for the safety and the well-being of their employees and their customers. We were among the first jurisdictions, if not the first, to do so. Our protocols for sectors that are open are also written as legal requirements and not as recommendations. We set up a complaint line where violations can be reported, and we've deployed dozens of health inspectors to follow up on violations. However, this work is best done in partnership with the businesses so that they can make sure that all workers are protected. We all share a common goal: slow the spread by preventing employees, customers, and visitors at any facility in the county from transmitting the virus or becoming infected. Business owners and operators have a corporate, moral, and social responsibility to their employees and to their employees' families. to provide a safe work environment that adheres to every single one of the health officer directives. This responsibility is more important than ever as we continue to fight this deadly virus. And now I want to also look at some of the data around what we know by race and ethnicity and by poverty levels. So I'll take the next slide. First, let's look at the case rates by race and ethnicity. As you can see by the yellow line on this slide, Latinos, Latinx community is more than twice as likely as white people to be infected with the virus. Latino people and Latinx people are also twice as likely to die of the virus, and we'll show that in a minute, when compared to white people. And compared to white people, black people are 25% more likely to be infected with the virus and almost twice as likely to die from it. That's the green line that's on the graph. The next slide, please. Next, I want to look at differences by community poverty rates. And on this slide, the yellow line shows the case rates for communities with the highest rates of poverty. And you'll see that these communities continue to experience almost 3 times more cases than communities at the bottom, which is the blue line, that have little or no poverty. And people in communities with high levels of poverty are 4 times more likely to die of COVID-19 than are people in communities with low levels of poverty. As with other disproportionately impacted groups, the high rates of cases and deaths reflect a number of factors, including the effects of systemic racism and discrimination in our country and a lack of access to the resources and opportunities that people all need for good health. This includes living in more crowded housing conditions that make it physically hard to distance, having employment in work settings that have insufficient protections, and having more serious risk factors for COVID-related illness, such as heart disease, respiratory disease, and diabetes. And most importantly, continuing to have less access to the health care and the support services that really help all of us remain healthy or return to health after we're ill. We'll take the next slide. This slide just really highlights again the mortality rate differences that are experienced by race and ethnicity and by areas of poverty here in LA County. And as I noted before, Black and Latino residents in the county are twice as likely as white residents to die of COVID-19, and those that live in communities with high rates of poverty also experience a disproportionate burden, and they're 4 times more likely to die of COVID-19 when compared to residents that live in communities with the highest incomes. The data that I'm reporting to you today is disheartening and distressing, and it shows that we're not yet doing enough to address these inequities in our community. I'll take the next slide. Some of our efforts, such as improving access to testing, have been successful, as seen on this slide, which shows us that people in the neighborhoods with the least income, which is the orange bar on the right, are more likely now to have been tested. From the very beginning of the pandemic, it's been a top priority for LA County to ensure that all residents have access to testing regardless of their income. And this is especially important since communities with the highest poverty rates have been especially hit hard by this virus. However, a lot of work remains to be done. Additional strategies and investments are needed to ensure that those communities experiencing the highest rates of COVID-19 have resources that allow residents to be connected early to care and to social services. We need additional support for low-wage workers so that they're able to both easily report violations and also connect to resources for elevating critical concerns. And we need to be mindful that trusted organizations in communities where they're experiencing elevated risk need to be supported so that they can communicate and disseminate accurate information about the virus and strategies for protecting oneself and one's family. So although we're now in this very troubling phase of the pandemic, I know that with a lot of hard work and our collective efforts, we're going to get to move forward, and we're going to get back to flattening the curve. We did it before, we need to do it again. And it only is going to happen if we're all working together. So as a reminder, please stay home as much as you can. If you do need to go out for work or important errands, always wear your face covering and wear it correctly. It needs to cover both your mouth and your nose. If you don't wear a face covering correctly, it protects no one. And remember, even though we all miss summer barbecues, pool parties, and other fun and normal things we would be doing on a hot summer's day in July, it still isn't safe or smart to return to seeing friends and family that you don't live with. You could be infected without knowing it, and you could pass along the virus that could be fatal to someone you love or someone I love. And while these are disappointing realities, it should be of some kind of comfort to know that our behavior and the simple actions of kindness and sacrifice end up protecting those we love and those who are most vulnerable in our communities. And ultimately, it's these acts of kindness that get us back to the road of recovery. And now I'm going to turn it over to my colleague, Dr. Christina Galley, the Director of the Department of Health Services.
Hi, good afternoon. I'm Dr. Christina Galley, the Director of the Department of Health Services. As Supervisor Solis mentioned at the beginning of today's briefing, I will focus on what we're seeing from an equity and access perspective with respect to testing across the county. DHS is working swiftly to mitigate the impacts and provide support for the communities that are most in need of help. Before I get started, I want to take a moment to say I know that this is all a difficult time for everyone. The fight against COVID-19 feels like a lot to handle. I continue to urge each and every one of you to do what you can to protect your mental health and that of those around you. Go for a walk, interact with your friends in a safe way, socially distanced, and reach out to your doctor and to a mental health helpline if you need assistance. Unfortunately, while we are all impacted in innumerable ways by COVID-19, the impact on some communities and groups of individuals is more serious than that for others. We know, and as Dr. Ferrer just walked through in detail, certain communities, particularly low-income communities and Black and Brown communities, are disproportionately impacted by COVID-19. And that understanding is and has been guiding DHS's response with respect to testing to this point. DHS has taken a geographically focused approach in setting up and supporting testing locations across the county in a way that ensures equitable distribution of resources and in a manner that is sustainable across the county's diverse communities. As we work to integrate testing into the established healthcare system, we're also working with providers who are trusted resources within these communities, who are known and trusted and respected by the residents who live there. People in these at-risk communities can come to any county testing site or city testing site, or can go to any one of a number of these trusted provider partners, including clinics operated by the Department of Health Services, as well as other community clinics and federally qualified health centers. We are also working with clinics to support their ability to be able to provide testing services to their patients. This includes communication support, technical assistance on reimbursement and billing, connections with labs if people don't have familiarity, and assistance with access to PPE and other resources as needed. Even though we have been focused on the issue of equity and access to date, there is a lot more work that needs to be done. The data that DPH has shared on the disproportionate mortality that the Latinx and Black communities experience in particular make this crystal clear. While testing is not the only component of the response to address these racial and ethnic disparities, it is one important piece. Given that, I'll begin by providing an update about how the COVID-19 trends are impacting certain communities more than others, so we can talk about what DHS is doing from a testing perspective. The next two slides, if you'll turn on the slides, the next two slides look at the percent of tests that are positive by race and economic status. And Dr. Ferrer just went through a version of these, but I want to walk you through them as well. Test positivity is an important indicator of both the trajectory of the pandemic as well as our ability to provide sufficient testing to keep transmission low. This first slide is on test positivity by race. The rate of positive tests is much higher among the Latinx community than it is among any other racial or ethnic group, a trend that has held constant for months. Further, white individuals have consistently the lowest rate of test positivity. This can reflect the greater relative access to and use of testing resources by white populations, and also their reduced risk of being exposed to COVID-19, a fact that Dr. Ferrer also just walked through with some pretty stark data. This is due to the fact of many factors: multi-generational housing, their use, their employment in essential functions that are not easily able to enjoy the privileges of telework, among multiple other factors. Sadly, the underlying reasons why communities of color are disproportionately impacted by the worst outcomes of COVID-19 is related to long-standing structural and systemic issues, including social determinants of health, that the county is working to address and mitigate in the midst of this pandemic. Even though testing utilization is relatively higher among certain communities of color, more clearly needs to be done. On the next slide, we will also look at the test positivity rate by area of poverty. These findings are also very concerning. It shows a direct correlation between poverty level and test positivity. The lower one's income, the higher the rate at which they are testing positive for COVID-19. Poorer areas and the poorest areas are the most impacted, as shown by the red line, and those areas with the least incidence of poverty are shown in the light blue line and are impacted the least. This reflects, again, the burden that our low-income communities face in terms of their exposure to the virus, and also the fact that they were not, and still are not, accessing testing at an appropriate level given their degree of burden. We also need to recognize, though, that adding testing capacity is needed. The demand has outstripped the supply among those who want to have tests, and more needs to be done. That's why, though, because of these charts that we've just gone through, we have an obligation to add the capacity in a manner that addresses the stark disproportionality of necessary testing access that is facing certain vulnerable populations. With this in mind, we undertook a data-driven approach to understand how we can push for equity and access to testing for those who need it most. So shifting to the next slide, you'll see a heat map. All of this is on the DHS and the county COVID website. A heat map that identifies the hotspot communities where the compilation of available metrics indicates that these communities have the greatest need for increased testing access. These hotspots are defined by 3 different metrics. First, test positivity rate, which we've just walked through, and there's certainly a disproportionate burden borne by low-income communities and persons of color. Second, the COVID mortality rate, which we also know disproportionately affects individuals who are low income and persons of color. And please note that we have removed the deaths in skilled nursing facilities and taken into account these numbers to focus just on the community-related deaths. And also the testing rate, or the rate at which people are accessing testing services broadly, regardless of where that test took place. This looks at communities that are not meeting the state threshold of 1.5 tests per 1,000 population. The communities that you'll see in red are those that have the greatest need. They do not have sufficient access to testing and have been disproportionately affected by COVID-19. So with that in mind, we are expanding the county's testing sites by 65% over the next couple of weeks, with the entirety of that expansion focused on areas of high need per the heat map that we've just walked through. This includes new testing locations that will be set up in Montebello, Southgate, Azusa, Panorama City, Compton, and Downey Norwalk. Of these 6 areas, we've secured contracts at the majority and plan for a launch on a rolling basis over the next 2 weeks. We are also adding access at existing testing locations in other high-need areas that were highlighted on that map. The 4 priority communities that we'll be adding access to first are Bellflower, Pomona, El Monte, and East LA. We appreciate the immense partnership with the various cities and local leaders that have really come to the table and helped us to quickly establish and expand these sites so that we can swiftly address the disparities that we all see. The above capacity is in addition to new testing sites that have been brought online by community clinics, by the Department of Health Services clinics, and by other partners, including pharmacies. I'll remind you that per the recent health officer order issued by DPH last week, and consistent with the sentiments that were relayed yesterday by the state in the launch of their renewed coronavirus testing task force, that providers are required to provide testing for their patients and plans are required to pay for it. This is a step in the right direction, but more needs to be done. Our efforts to address racial and economic injustices of COVID, we aren't only focused on testing capacity. There are several other areas of focus, which I will highlight just very briefly before I turn it over to Dr. Erica Flores Uribe, one of the individuals who is helping to lead our COVID equity work within the Department of Health Services. First, a site is not helpful, obviously, if people can't access it. We know there's a digital divide in the county. Please know that many of our sites have an option to sign up by phone. Internet access is not required, and we will continue to work to make sure that the options to sign up for testing by phone are expanded. There's also a misconception that individuals must have a car or be able to drive through in order to obtain testing. This is absolutely not true. 38 testing sites currently within the county are walk-through testing sites, not drive-through testing sites. The map on the COVID-19 county website distinguishes between drive-through and walk-through testing sites so that people can select the model that best suits their needs. We will also continue to prioritize addition of both walk-through and drive-through sites as the pandemic continues. And finally, looking toward a solution long-term for how we can protect people with COVID, DHS is actively looking for ways to ensure that all communities we serve are appropriately and fairly included as full partners in research efforts to develop new treatments and vaccines that it will allow all of us to put the pandemic behind us for good. Testing sites can be one of many important access points of entry for such studies. In order to build on the efforts to support underserved communities by expanding testing, DHS has allocated $4 million from a grant from the Centers for Disease Control to support outreach in our most impacted communities. This funding will support a wide variety of communication efforts from broadcast media to grassroots in-language, culturally responsive messaging campaigns. It will also support work with community-based organizations to perform outreach, provide information and education to community members, engage them and link them to COVID-19 testing, healthcare, and other supports like housing access, food access, and health insurance. Understanding the historic limitations to access and the potential mistrust of the healthcare system that many of our highly impacted communities experience, DHS is investing in these communities and in the community-based organizations that are trusted in collaboration with the Department of Public Health. By collaborating and funding partners who are embedded already in these communities as trusted messengers, we will more effectively reach our most at-risk and under-resourced communities. I'd now like to invite Dr. Erica Flores Uribe, the Director of Language Access and Inclusion with the Department of Health Services, who, with Dr. Clemens Hong, is co-leading our outreach and community engagement work. She'll share an update just briefly on some of the successful models that we've piloted to date and how we might roll these out in the future. After that, I'll return briefly to discuss criteria for testing and the hospital demand trends.
Thank you for that introduction, Dr. Galley. As Dr. Galley discussed, this work is not just about adding more testing sites in areas that are highly impacted. It doesn't stop there. It's about funneling resources to communities that have been historically under-resourced, especially as we see the rise in COVID-19 in communities of color. Both Dr. Ferrer and Dr. Galley highlighted this rise, particularly in the Latinx community. These make resources such as in-language and culturally responsive support services even more critical. The county and the Department of Health Services is responding. DHS, in collaboration with other county partners like the Department of Public Health and community organizations, are meeting under the Advancement Project to develop recommendations on how to best coordinate community-based organization engagement, education, outreach campaigns, and system navigation. Today, I will provide a brief overview of how DHS leverages public-private partnerships to support our communities and how identifying geographic areas of need through the hotspot maps discussed by Dr. Galley allows DHS to continue to commit, prioritize, invest, and expand these efforts to reach our most vulnerable populations. One example of a successful public-private partnership is our testing site on the campus of Charles Drew University. This operates in partnership between our MLK Outpatient Center and Charles Drew University. This site in a high-risk, vulnerable area in South LA has proven successful in reaching those that we saw in the positivity charts earlier disproportionately impacted and live in areas that the map indicated have limited access to testing. A recent report from this site highlights the following best practices. By partnering with trusted community partners for grassroots communications, like flyer distributions in local venues like grocery stores and faith-based organizations, as well as through in-language and culturally responsive messaging via several media outlets, high-risk communities were most effectively reached. In fact, these outreach efforts effectively reached a population of 86% self-identified communities of colors. This is completing over 1,000 tests on average per day at this site. The data from this report shows that 70.7% of those tested identified as Latinx. They made up 88.8% of those who tested positive. This is one of the highest positive infection rates of one race and ethnicity group. Once engaged through the testing site, the MLK CDU staff screens community members for housing, mental health, and other social services needs, in addition to connecting them to medical care. In fact, these efforts identified that over 30% of those tested did not have a primary medical home. In high-risk and high-impact communities like this, MLK CDU model was a successful example of how a DHS COVID-19 testing site can function to link the community to medical care and support services during this difficult and economically uncertain time. We are looking to support other sites in high-risk areas to follow a similar model like this one, utilizing hotspot mapping to identify the hardest hit communities allows for not only mobilization of testing resources, but also mobilization of support services and protective supply to highly impacted communities. For example, given the rise in COVID-19 numbers that we saw in communities like South and East LA, we effectively partnered with the United Healthcare Group to distribute over 10,000 resource kits. This distribution happened out of our MLK CDU site, and it was a donation valued at over $400,000. This distribution has been happening over the last couple of weeks, and it's providing our community with essential needs like face coverings, food vouchers, and hand sanitizers. This is also an opportunity for us to share with our community educational material that's in language and culturally responsive. This material provides information on when and how to seek care, as well as how to seek other protective services and stay safe during this time. One of the community members shared that there is a need for PPE in the community. People have to decide between food versus buying masks. It's going to be food. I'm glad that there is PPE where it's needed. Across the county, we're utilizing a similar approach to distribute protective resources and educational material directly to trusted community members and businesses in high-need areas. Countywide, in June, DPH and DHS partnered with the Advancement Project to distribute protective equipment to our most impacted communities. This distribution is almost 1 million face coverings, several thousands of hand sanitizers and face shields, and educational material that reached over 120 community-based organizations. These organizations share that Many establishments will not allow people to use their services unless they have a mask. Many community members are left without services due to inadequate access to masks or having old, worn-out masks. By having PPE distributed by DHS and DPH, they are not able to go into businesses like grocery stores, use public restrooms, and attend service-based events. I want to thank our partners in these efforts, and I want to share that we are committed to continuing this work to support communities that are most impacted by COVID-19. I'd like to hand it back to Dr. Galley now.
Thanks, Dr. Uribe. I'll shift now to provide an update on who is prioritized for testing in the county and then briefly touch on the hospital bed demand model. There are many media reports that as a result of increased demand for testing over the last week or two, that the county changed its testing criteria. These reports are absolutely wrong. The Department of Public Health announced its revised testing criteria, which is posted on their website 6 weeks ago on June 2nd. That criteria highlights the following populations as being recommended for testing: those who have no symptoms, those who have symptoms, those who have a known exposure to someone who is positive for COVID-19, and those who live or work in a high-risk setting, such as a skilled nursing facility or a homeless shelter. Implementing this guidance was an involved process at our testing sites. This criteria will become effective at LA County and LA partner sites today. In addition to the populations I just mentioned, essential workers will also still be prioritized for testing in line with the new criteria that was released by California Department of Public Health yesterday, though the state makes it clear that the higher priority should be given to populations that are listed in the LA-DPH guidance. So if you are unsure of whether or not you need a test, first, check with your healthcare provider. Unless you have specific symptoms, live or work in a high-risk setting, are an essential worker, or a known close contact of someone with COVID-19, you may not need to be tested, and your healthcare provider can talk to you about your concerns, your risk exposure, and your specific situations. If you don't have a doctor, you can call the county's 211 line to get a referral. As I mentioned previously, healthcare providers are now required by LA County Health Officer Order to provide their patients with access to COVID testing, just as they do for any other condition. The Health Officer Order also encourages providers to bill private insurance plans for these services when necessary. Patients are not allowed to be charged by their plan or their provider for COVID-19 tests. As mentioned on the state call yesterday also, the State Department of Managed Healthcare will also be coming out with additional guidance on this subject in the next couple of days. Obtaining a test through your regular provider or the provider network helps to assure tailored clinical advice that takes into account your specific history and facilitates good follow-up in case of a positive test result. I'll turn now very briefly to touch on the hospital bed demand model. This week's data demonstrates an increasing number of new daily hospitalizations that is driving an increase in the overall number of patients hospitalized in the county, a fact that Dr. Ferrer walked you through on the slides previously. There has also been an increase in patients that are requiring ICU care and ventilators, and sadly, an increase in the daily reported mortality. All of this suggests that transmission is increasing in the community. The model currently estimates the effective transmission number at 1.07. If this continues, while we do have a sufficient number of beds and ventilators, the number of ICU beds, as I've shared before, is more limited and may become inadequate. The EMS agency, working in partnership with the Department of Public Health and with the private and public hospital community, is working to implement private hospital and public hospital surge plans and disaster plans to support their staffing needs and to support the ability to move patients fluidly in and out of the hospital as needed. A full set of slides and the model predictions are posted, as always, on the DHS and county website in both English and Spanish. In closing, our focus is on doing everything we can to support the health of the general public with a specific focus of support and resources on the communities that are most suffering from COVID-19, and also on preserving our hospital system for all of those who might need it, whether they have COVID or don't. We continue to ask that everyone stay home as much as possible and wear your face covering when you are outside. This is not the time to let our guard down. Everyone, as Supervisor Solis walked through with that story today, everyone can be affected by this virus. It isn't just the elderly, it isn't just people with underlying health conditions, it isn't just people in skilled nursing facilities or homeless shelters. It isn't just people who live in any particular zip code. We all must do the basic things: wear a mask, stay at home, isolate when sick, quarantine for the full 14 days regardless of the test result. All of these simple basic steps will help us to stop and slow the virus transmission and get it back under control. It will protect your life and that of those you love. With that, we'll turn it over to questions.
And ladies and gentlemen, if you wish to ask a question, please press 1, then 0 on your telephone keypad. You may withdraw your question at any time by repeating the 1-0 command. And if you are using a speakerphone, please pick up the handset before pressing the numbers. Once again, for questions, you may press 1, then 0 at this time. We'll go to Claudia Paschuta with KNX News Radio. Your line is open.
Thank you. What is the range on the transmission rate? Because it's so close to 1. I'm wondering, is it definitely above 1, or is that unclear at this point? And then also, do we have a new estimate on the number of LA County residents believed to be infected and who may be unknowingly infecting others? And then also, if you could explain, given that hospitalizations and daily case counts are higher than they've ever been in LA County, why are we not seeing the kinds of steps taken earlier in the pandemic, such as the opening of the Surge Hospital or getting a naval hospital shipped to the area? Thank you.
Thank you, Claudia. We'll have Dr. Ferrer answer those.
Thanks. Oh, sorry. Thanks so much, Claudia. Yeah, I think a couple of things are important to note. Early on in the pandemic, we didn't really have a lot of information about what we anticipated could be a pretty steep increase in hospitalizations, and everybody at the very beginning was really doing all they could to make sure that we had enough hospital beds. I think we've learned over time how we need to prepare for increases in caring for people who need hospital care, and at this point there really is no need to open the additional facilities. And just to note that the biggest issues that we have in all of our healthcare settings is making sure we have enough workers to staff all of the beds that are available. So I think Dr. Galley can talk more, but this is a system-wide approach, and I think some of the things we did at the very beginning we actually don't need to do now, because we've learned a lot about how to manage caring for people who are sick with COVID-19 in our hospitals. We've also learned a lot about how to predict what we think might be the need for additional beds in the future. It's all of the modeling, it's all of the good data points that we have now, and most of all, it's a lot of experience from the past 5 months of managing this. And I think the same is true of what's going on with sort of the increase in cases, and how are we really preparing ourselves for what could be continued increase in cases. Obviously, the first job that public health is working the hardest on is preventing additional unnecessary transmissions. This is a virus where the best we're going to be able to do is slow the spread. We're not going to be able to actually stop the spread right now, but slowing the spread is critically important. And again, we know that there are a lot of action steps that we can take. I think most important has been noting that this virus is more easily transmitted and is more capable of infecting people when they're inside. So you see a big push to try to get as many activities as we can outside, and then if they are outside, to continue to do all of the infection control and all of the distancing. Our hope is that the behavior we're seeing, and have seen this last week, as we've started closing down some of the opportunities for increased transmission in indoor settings, will lead us to get back to slowing the spread. I don't think there's a magic number here that we're aiming for, but clearly we don't want to continue to see upwards of 3,000 or more cases, new cases a day, in order for us to claim that we're successfully managing to continue slowing the spread. But I'm going to turn it over to Dr. Galley about the modeling question.
Hi. First, I want to underscore what Dr. Freer just said about the alternative care sites. Alternative care sites are brought online when the biggest problem is the physical bed space, when there's not enough physical space to have patients safely within the existing hospital system. That's not the issue. The issue that is most constraining the supply of available beds is staffing, and alternative care sites do nothing to resolve that problem. So rather, what's needed is to focus on those staffing resources. We're appreciative to the state for their assistance and for federal resources as well, but this is something that we continue to work on with both public and private hospitals. In direct answer to your questions, the effective transmission number is 1.07 with a range of 0.94 to 1.2, and the estimated number of individuals who are infected and not isolated, so infectious to others, is estimated at 1 in every 230. We'll turn to the next question.
We're going to Conan Nolan with NBC Los Angeles. The line is open.
Dr. Ferrer, very quickly, some clarity on the contact tracing that you've done thus far. We've been hearing anecdotally that much of the spread, the vector for the spread, has been in office buildings such as LA Apparel, where they had an outbreak, 300 individuals. And then there's this question of family get-togethers. But does the contact tracing point to any specific areas that you can give us? And do you have any evidence of people who've contracted this disease outside?
Yeah, these are such good questions, and obviously I wish I had really definitive answers. We do, the problem with contact tracing is it doesn't necessarily always identify the source of the infection for the case. Many times, because there's a long incubation period and because people are actually infectious a couple of days before they actually develop symptoms, if they're going to get symptoms. And for asymptomatic people, it's really even harder to tease out. It gets so complicated to figure out for everybody what exactly was the source of exposure that led them to become positive. And the most important thing for us to note is that oftentimes people have potential multiple sources of exposure. The times where it's the easiest is when it's really clear that I know I was at a gathering and a person was positive, or I had a work exposure and one of my coworkers was positive, or I, in fact, went out to a setting where I was notified that, in fact, somebody who was in that setting with me was positive. I do want to provide the things I do know I can assure you of is that, yes, there is transmission outside. Clearly, there have been a number of family gatherings and social events that people have held outside, 100% outside, where there's been family members or family members and friends who have all become infected from a common exposure. And in that case, it was easy to sort of trace where, in fact, the source of infection was. So while it's obviously harder to get infected if you are outside, it's pretty easy to get infected if you're outside, you're not doing any social distancing, you're not wearing a face covering, and you're taking no infection control practices to heart. So there's not a lot of washing hands, people are sharing utensils, people are sharing food, pretty easy to think about how there could be transmission in those settings, whether you're outside or you're inside. So I want to make sure people are clear that outside is better in terms of air circulation, but better in this case means you're still doing all of the distancing and infection control that you're being asked to do in order to minimize those exposures from resulting in people actually getting infected. So we'll go on to the next question.
Yes, that is from David Rosenfeld with LA Daily News. The line is open.
Hi, good afternoon. Thank you so much for all the information. It's really quite a lot to digest. I was wondering if you could expand a little bit more on where the healthcare workforce is going to come from. We've heard about the state's health corps. I think maybe there might be some Department of Defense piece to it that might be coming in. I wonder if you can provide any more details on that. I also missed the current hospitalization number. I'm wondering if you could repeat that, please. And in terms of testing, could you just clarify the sites that you mentioned? I think there were 4 sites that are online this week, and then the others were planned for coming weeks. Is that correct? That's all. Thank you.
Yeah, we'll have Dr. Galley begin and then Dr. Ferrer.
Hi. So the first question with respect to staffing, so yes, you touched on this, the main state and federal resources, federal side, Department of Defense, Medical Reserve individuals are being deployed to California with 2 teams coming to Los Angeles County. The state health corps with a number of individuals that they're working on processes for mobilization. That's in addition to all of the efforts that hospitals do normally and under surge conditions as written into their surge and disaster plans to identify and onboard additional staffing. That includes looking at recent retirees or individuals that recently left the organization, deploying and reassigning individuals who work in administrative functions but have clinical experience and clinical expertise, people who work in outpatient settings and reassigning them to inpatient work, bringing on additional staffing through contract or registries. There's a number of steps that hospitals will go through to supplement those staffing needs. I'll turn it to Dr. Ferrer for the second question, but I'll touch briefly on the third. The 6 sites that we will be launching as new sites, and then the 4 sites that we have plans to add, supplement the test capacity in, those will launch on a rolling basis over the next 2 weeks.
Today, there are 2,193 people that are hospitalized with COVID-19. Oh, and we'll take the next question.
Thank you. We'll go to Christopher Weber with the Associated Press. The line is open.
Hey, thanks. On Monday, Mayor Garcetti said that we are near the red zone, close to having to go back into a complete lockdown. Is another stay-at-home order possible for LA County if the trend lines that you outlined don't improve? And if so, how soon could the closures be imposed?
Yeah, thanks so much for that question. I'm sure it's top of mind with almost everybody who lives here and works here. We can't take anything off the table. There's absolutely no certainty of what exactly is going to happen next. We do know for a fact, though, that we have to do everything we can to protect the healthcare system for everybody, not just for people who are sick with COVID-19, but people who have other illnesses that require care in our hospital setting and in other healthcare facilities as well. And that's why nothing can be off the table. Do we want to go back to a safer at home order, really closing everything down again? Absolutely not. None of us want to go back there. But if we had to go back there, because we were getting to the point where it was pretty clear we were going to overwhelm the healthcare system, we would have to keep that option on the table. What I can honestly just say as a person who lives here, it's kind of in everybody's hands right now. We slowed the spread before, and that's why I say it's in everyone's hand. We did slow the spread before. We slowed it very successfully here in LA County. The largest county in the country managed to actually slow the spread. And we slowed the spread at a time where we actually didn't know as much as we know today about how to protect each other. So we know more. We know how important it is to wear those face coverings. We know how important it is to keep our distance from other people. We know how important it is to do basic infection control. And we know how important it is for those businesses that are open right now to protect their workers, their customers, and their visitors. These are things that are for certain. And it's for certain that if we do a really good job on implementing all of the tools that we have at hand, we can get back to slowing the spread. And that makes it much less likely that we return to safer at home. We don't have a lot of time, though, because we're already, as you see, every day that we talk to you, you see we're increasing the burden of care that's required for hospitals to provide. And at some point, you turn that corner where you're actually expecting hospitals to provide way more care than's possible. We can't get there. And so if all of the steps we're trying to take collectively don't work to stop us from getting there, we're going to have to dig deeper into the toolbox around the strategies of sort of what should be open and what should be closed. I think right now it's pretty clear that the message is out there about trying to slow the spread by closing some sectors and then asking some sectors to move activities outside wherever possible. And I'm hoping that this strategy works, but it goes hand in hand with everyone doing their part. And we'll take the next question.
And that is from Haley Winslow with Fox 11. Your line is open.
Hi, Dr. Fair. Thank you very much for taking my question. Some health experts are warning of potential long-term health problems from the virus affecting people of all ages. Can you shed any light on, even if you recover from COVID-19, possible long-term effects, not only blood clots and potentially strokes, but for instance, lung damage?
Sure, it's such a good question. I think it's such a stark reminder of the fact that, people may in fact recover in the sense that they get to leave the hospital, but many people, thousands of people have been left, as you noted, with debilitating illness that seems to last for a much longer period of time than they expected or we anticipated at the beginning of the pandemic. So I do think it's important for everyone to take note of the fact that, just like you mentioned, there are now numerous, not just anecdotal stories, like, oh, I heard this from a friend, but numerous research studies that point to the fact that for a subset of patients, recovery has been very, very difficult, and there have been lingering serious effects from the illness. And as, again, as scientists and researchers struggle to better understand how this virus interacts with human beings, I think one thing is clear is that as with other viruses, different people will have a different response to the virus and a different path towards recovery. So I think as Supervisor Solis showed us at the very beginning, this can cause so much heartache, this virus. And a lot of people just go around saying, most people don't get seriously ill. But most people isn't everybody, and lots of people, lots of people end up pretty sick from this virus. And some of them, as you're noting, have a very, very long and arduous road on their recovery journey. So I appreciate that question. And as we learn more, we'll be able to, perhaps be able to pinpoint some of the reasons why, for some people, the recovery journey is particularly difficult and causes a lot of lingering, serious side effects. We have time for one more question.
Thank you. That is from Nathan Solis with Courthouse News Service. Please go ahead.
Yeah, hi. Thank you for taking the questions from all of us. I was just curious to know if there have been any research on the quality or characteristics of the virus in Southern California, if anything about it is unique, and they could explain the rapid increase of infections.
Dr. Ferrer.
It's a tough question to answer definitively because, as everyone has read, there are now, ample studies that indicate that there have been at least one serious mutation, but that mutation doesn't seem like it's associated with more serious illness. I think we just have to continue to learn more to be able to answer anything definitively about what's happening here in LA County, as well as how does that compare to what's happening in other parts of the country and other parts of the world. So, we try to stay on top of, again, what we're reading and what we're learning. We're really blessed here because we have a lot of researchers right here in LA County that are looking at sort of the sequencing of the genes to try to really understand what's going on. But I don't think we have a definitive answer yet on is there something special that's been happening here. And again, we're in the process of doing another round of seroprevalence another round of serology testing. I think the testing will start later on this week. So we'll have a third round of results that we'll be able to share that I think, again, allows us to do some comparison with what we're seeing here in LA County and what's been seen in other places that are doing surveillance serology testing. Remember, that's the antibody testing that we do. So, I hope we continue to learn more and we can more definitively answer this question. But now we'll turn to remarks in Spanish from Supervisor Solis.
Buenas tardes y gracias por acompañándonos ahora en esta conferencia de prensa. Mi nombre es Hilda Solís, soy la vicepresidente del Junto de Supervisores en el Condado de Los Ángeles. El crisis se está intensificando. Por eso hoy vamos a anunciar que vamos a ampliar la capacidad de ofrecer más pruebas de COVID-19 en el Monte, en el Colegio Comunitario del Este de Los Ángeles y en el Pomona Fairplex. También vamos a abrir nuevos sitios en donde personas pueden hacer la prueba de COVID-19. Estos nuevos sitios estarán en lugares como Azusa, Montebello y Southgate. Tenemos que hacer todo lo posible para enfrentar este virus. Para llamar la atención sobre la gravedad de esta situación, me gustaría compartir la historia de un joven sobreviviente de COVID-19 con quien hablé la semana pasada. Ella tenía 33 años y se consideraba como una atleta.